All right, we'll go ahead and begin. Welcome to today's webinar hosted by the Tiny Baby Collaborative. Our topic today will be bacterial and fungal infections in infants born before 24 weeks gestation. My name is Noelle Young. I'm a neonatologist at Duke University in the US, and it's my pleasure to introduce our speakers and moderators for today's webinar. Starting us off, we're going to hear from Dr. Dustin Flannery. Dr. Flannery is a neonatologist at Children's Hospital of Philadelphia in the US, and his talk will focus on bacterial infections. And then we'll hear from Dr. Katrin Mehler, who's a neonatologist and infectious diseases specialist at the University of Cologne in Germany, and her talk will focus on fungal infections. We'll then have time for questions and discussion led by an esteemed panel of moderators. We have Dr. J.B. Canty, who's a neonatologist and infectious diseases physician at the University of Texas, San Antonio, Dr. Joseph Ting, a neonatologist at the University of Alberta, Dr. Lena Mithal, a pediatric infectious diseases physician at Northwestern University, Dr. Michael Cotton, a neonatologist at Duke University, and Dr. David Kaufman, a neonatologist at the University of Virginia. Just a few housekeeping items to get started. This webinar is being recorded, and the recording will be posted to our website, tinybabycollaborative.org, for later viewing. We welcome multidisciplinary attendance, including clinicians, researchers, and families. If you have questions that come up during the webinar, please use the Q&A button in Zoom to send the questions, and we'll address as many as we can during the discussion section at the end. We're happy to have a multidisciplinary group in attendance today, including neonatologists, nurses, nurse practitioners, fellows, and others from over 40 countries. We asked a few practice survey questions in the registration form, so I'll take a minute to review the responses. First, we asked whether you use prophylactic antifungals for infants born less than 24 weeks gestation, and you can see that we had a pretty even split in the responses, with just under half answering yes. And among those who answered yes, 44% reported using antifungal prophylaxis for the duration of central line use. You can see around 15% reported using it for longer than 6 weeks, whereas the rest of the responses reported using shorter courses. We also asked about choice of empiric antibiotics for early onset sepsis, and you can see the majority of responses were ampicillin and gentamicin. But for empiric antibiotics for late onset sepsis, there was more variability, with more frequent use of vancomycin, nafcillin or oxacillin, cephalosporins, piperacillin, tazobactam, and amikacin. In preparation for today's webinar, we took a look at the mini data set, which is our registry for the Tiny Baby Collaborative. And you can see here, among over 1,000 babies that were admitted to Tiny Baby Collaborative hospitals born at 22 to 23 weeks gestation between 2019 to 2024, around 1 in 15 had culture-positive early onset sepsis, around 1 in 3 had late onset sepsis, and around 1 in 25 had invasive fungal infections. So clearly this remains an important problem in this population, and I'm looking forward to learning from our presenters and our discussion today. So with that, I will hand it over to Dr. Flannery to go ahead and get us started.
All right, Noelle, does that look okay?
Yes.
All right, thank you so much for having me. I'm extremely excited to present some of these data today. Again, I'll be speaking about bacterial infections in infants born less than 24 weeks. And I do want to just give the caveat that most of these data are based from studies in the US. So I know there are international folks on the call, and so that's something to take into consideration when interpreting the data. I have no conflicts of interest, and I do receive grant funding from ARC. And the outline for today, I'm mostly going to talk about early onset sepsis and late onset sepsis and the epidemiology of these two entities, including the incidence, microbiology, related outcomes. I'll talk briefly about risk assessment. How do you decide who you need to evaluate for EOS or LOS? I'll talk about the pros and cons of different empiric therapies. As you can see, there's some variation, particularly for late onset sepsis across the groups. And then I'll end by just highlighting some of the concerns about the global threat of antimicrobial resistance and how that impacts care of these tiny babies. There are many things that I won't be able to talk about today. One, because I don't have enough time, and two, I just don't have the expertise. That includes skin and soft tissue infections, ventilator-associated pneumonia, respiratory infections, and more. I just also wanted to point out the setting that I practice in. I primarily practice in two hospitals. The first one on the left is Pennsylvania Hospital. This is the first hospital in the United States. This is a 50-bed level 3 NICU. This is the busiest delivery center in the city of Philadelphia. And we've sort of developed a culture of caring for infants almost routinely at 22 and 23 weeks over the last couple years. And then the other hospital I practice in is the Children's Hospital of Philadelphia. It's a 110-bed level 4 NICU that doesn't really care for many of these babies early on, but often cares for them later when they require more advanced care. And I think we say this a lot in pediatrics, that children are not small adults. I think as neonatologists or folks interested in neonatology, we would agree that preterm babies are not just small term babies. The pathophysiology and the medical management is very different. And I would argue and sort of set the stage for the talk today by saying that babies born at 22 to 23 weeks, like this little baby on the left, are not simply just small 26 to 28 weekers. And so we can't just transcribe their care onto these smaller babies, as they do require some different modalities and thought processes. These are data from the Neonatal Research Network, a consortium of about 18 academic centers across the US. And this is the incidence of early onset sepsis from 2015 and 2017. And they broke it down by gestational age groups. And you can see that the highest incidence of early onset sepsis was among the very preterm group, so 22 to 28 weeks. But they did not break it out further by gestational age, mostly due to the sample size. And some interesting things that we learned from this study, led by Barbara Stoll in the NRN. First, there are some pretty interesting differences in the incidence of infection, pathogen-specific infection by gestational age group. And so they focus mostly on group B strep and E. coli. And you can see that there's a substantially increased incidence of E. coli early onset sepsis in the 22 to 28 week group compared to the other gestational age groups. And that difference, shown here visually, is really drastic when you look at the discordance between the E. coli incidence at 22 to 28 weeks versus other gestational ages. And also compared to GBS. And I highlighted the y-axis here to show you just how drastic that difference is. And so for GBS, the difference between 22 and 28 weeks and 29 and 33 weeks, not that different, maybe 1.1 per 1,000 to 1.3. But when you move over to E. coli, the incidence at the 22 to 28 weeks is over 12 per 1,000, whereas the 29 to 33 week group, it's just about 2. And so we wanted to look at this even further. And so we teamed up with Erica Edwards and Jeffrey Horbar and some colleagues at the Vermont-Oxford Network. And we completed 2 studies using data from the Vermont-Oxford Network, again, from US centers. And so for the early onset sepsis study, we had over 700 US VON centers. We included very preterm babies, which we defined as gestation less than 30 weeks, or birth weight less than 1,500 grams. And this was back in 2018 to 19, and this is over 80,000 infants. And again, there's a striking difference, a 12-fold difference between the highest and lowest gestational age categories when looking at the incidence of early onset sepsis. And so really, the babies born less than 24 weeks have a much different and a much higher incidence of infection compared to other gestational age groups in that very preterm cohort. And if you do the math here, it's about 1 in 20 infants born less than 24 weeks that had confirmed early onset sepsis. And these are babies who survived, who first of all were actively resuscitated, survived the delivery room, and were admitted to the NICU. When we look at the microbiology of early onset sepsis, this is for all the very preterms, not just the less than 24 weekers. And you can see that E. coli predominates, making up about half of the infections. GBS is next, about a fifth. But 1/3 of the isolates identified were organisms other than GBS or E. coli. And so even though we focus on GBS and E. coli, we have to keep these other organisms in consideration. And this is a random smattering, including Staph aureus, Enterococcus, Haemophilus, Klebsiella, and other gram-positives and gram-negatives, and of course, fungi. When we look at the outcomes for early onset sepsis, this table is for all the very preterms, not just less than 24 weeks. And you can see that the infants who survived early onset sepsis were at increased risk for multiple morbidities. And we define those as chronic lung disease or BPD, brain injury, or retinopathy. When we looked at survival and survival without morbidity, specifically in that less than 24-week group, you'll notice there's really not a big difference in survival between the infants who had early onset sepsis and who did not. And that's probably because there's a low baseline survival at less than 24 weeks, and it may be, I don't know that we were powered to really detect a difference. But when we looked at survival without morbidity, there was a significant difference. Only 2% of infants born less than 24 weeks who survived early onset sepsis ended up surviving to discharge without morbidity. Moving on to late onset sepsis, we conducted a similar study. We expanded to include 2018 through 2020, again, over 700 US VON centers, very preterm infants, and the N here was about 118,000. And we found that the late onset sepsis incidence was highest among the infants born at less than 24 weeks. 1 in 3 had late onset sepsis. And again, these are among the babies who survived past day 3. We decided to look at the incidence of late onset sepsis or death, since they can be competing outcomes, given that if a baby dies early on, they may not have the chance to develop late onset sepsis. And again, we excluded those who did not survive past 3 days. And you can see here that for infants born less than 24 weeks, 1 in 2 either died or developed late onset sepsis. The microbiology of late onset sepsis, again, for all comers in the very preterm cohort, cons or Coagulase negative staphylococci were most common, making up about 1/3. Staph aureus was second, making up about 1/4. We were not able to distinguish through the VON data MSSA versus MRSA, although anecdotally and from other studies, we think MSSA is definitely more common. And E. coli was number 3. And then again, a smattering of other organisms, including group B strep, Enterobacter, Pseudomonas, fungus, and other gram-positives and gram-negatives. But then we wanted to look at the incidence of late onset sepsis by gestational age group and by pathogen to try to get a better sense. And I highlighted here the group that's less than 24 weeks. And again, these are babies that survived past day 3. And we found that 1 in 10 had a confirmed cons infection. 1 in 25 had a confirmed fungal infection. I have to put a caveat there that we did not have available data on fungal prophylaxis, so I'll let Dr. Mehler talk more about that. And 1 in 7 developed gram-negative late onset sepsis. 1 in 7 babies born less than 24 weeks who survived past day 3 developed gram-negative late-onset sepsis. Looking at survival of late-onset sepsis, this is for all comers in the very preterm cohort. Not surprisingly, late-onset sepsis was associated with lower survival for all gestational age groups, including those born less than 24 weeks. And similarly to the incidence, we wanted to look at late-onset sepsis survival proportions by gestational age pathogen or end pathogen. And so we wanted to be able to say, okay, if you're born at 24 weeks and you had GBS, what is your chance of survival? If you're born at 26 weeks and you had E. coli, what's your chance of survival? And you can see here that infants born at less than 24 weeks who did not have late-onset sepsis, in that top left in purple, they seemingly had lower survival than infants with some other types of infections. But we think that's probably related to the short median length of stay for these uninfected infants. And so in other words, some babies born at 22 and 23 weeks, even though they survived past day 3, they died shortly thereafter and just didn't have time to develop late onset sepsis, which we know the incidence peaks in that 2nd to 3rd week. Infected infants for all other gestational age and pathogen groups had lower survival, and survival was particularly lower for infants with gram-negative and fungal infections, 56% survival for less than 24 weeks with a gram-negative late-onset infection. We looked at some of the available outcomes in this data set, which are limited to hospital outcomes, not post-discharge. We looked at discharge on home oxygen, requirement of a tracheostomy, requirement of a gastrostomy. Again, these are just among survivors. And we found that for all 3, survivors of late onset sepsis had a higher risk of these technology-dependent chronic morbidities. I'm going to move on to just briefly talk about risk assessment and then empiric therapy decisions. And so this is the mindset that my group uses when we think about sort of the culture behind risk assessment or the culture behind obtaining cultures. And for term infants, really our goal is to look at a sea of well newborns and figure out which ones are at higher risk of early onset sepsis and should receive antibiotics. But really the current framework for preterm infants is the opposite, where we're giving most of them antibiotics. And right now, the field has been trying to identify those who might be spared empiric antibiotics, or at least not subjected to prolonged courses of antibiotics. And so the American Academy of Pediatrics released guidance in 2018 separately for term and preterm infants. The preterm guideline is for less than 35 weeks, so not specific to the very preterm group. And basically, the recommendation based on available evidence right now is to determine whether a preterm baby is born in a low-risk setting for early onset sepsis or a high-risk setting. Low risk is defined as an obstetric indication for delivery, a cesarean delivery, without labor, without induced labor, and with rupture of membranes just at delivery. And that's based on the known pathogenesis of early onset sepsis. And so this would be a mom who presents preterm with severe preeclampsia, undergoes a cesarean section, never went into labor, membranes ruptured at delivery. We think those babies are probably at the lowest risk. But if you're not in that scenario, you're automatically in high risk. That includes preterm labor, cervical incompetence, premature rupture of membranes, concern for intraamniotic infection, acute or otherwise unexplained onset of non-reassuring fetal status. And this is a large portion of preterm births. But we don't know right now is how can we differentiate these or stratify these even more. And so there's probably a medium risk category here, maybe preterm labor, but without concern for maternal infection, without preterm rupture of membranes. So how do we differentiate those babies in that medium risk category? And right now, I just don't think we have enough evidence to do that. The NANO trial, which is going on right now, may help shed some light on that. Also, some of our colleagues, including Dr. Coggins here at CHOP, is looking into risk-based stratification based on more detailed delivery phenotype. So instead of this binary categorization, is it possible to develop a preterm sepsis risk calculator? We know that's challenging due to the heterogeneity of the preterm population. And what about for late onset sepsis risk assessment? How do you decide with a preterm baby in your NICU whether or not you should evaluate them for sepsis? There are lots of reasons why you may decide to do that. I think the clinical status is probably the most important. Babies who have a change in clinical status or who are extremely ill. But we take a lot of other things into account. We look at lab work, CBC, CRP, procalcitonin, other biomarkers. Do they have a central line in place, which we know is one of the biggest risk factors? Other invasive devices, an endotracheal tube, a urinary catheter. When you're choosing those antibiotics, you take their surveillance into consideration. Are they colonized with Staph aureus or particularly MRSA? Or are you screening for VRE in your unit? We think about maternal infection history of prenatal, perinatal, and postnatal antibiotic exposures. Again, the degree of clinical illness. All babies at 24 weeks are inherently clinically ill. So how do you differentiate, what is more ill than you'd expect at that age? This is really reliant upon clinician judgment. There are some groups that are doing predictive analytics. Again, that's challenging due to the heterogeneity in the physiology of preterm infants at different gestations. So can you develop predictive analytics that can detect subtle differences in vital signs that is consistent between a 22-weeker and a 28-weeker? And then also abdominal concerns play in here. Are you specifically concerned about bacteremia, meningitis, urine infection, or is there some abdominal pathology that may be concomitant? And really, I'd say right now, we just don't have much data about how to accurately risk stratify preterm infants for late onset sepsis. And so there's quite a bit of variation. And so once you decide whether or not you want to evaluate a preterm infant for infection, how do you decide what antibiotics to give them, especially these babies born less than 24 weeks? We know that there's mounting evidence that early exposure to antimicrobials, particularly broad spectrum or prolonged exposure, is associated with multiple adverse outcomes. This has been shown in multiple observational studies. And this is really, it's a balance of risk. And so if you think about the pros and cons of using a narrower spectrum regimen, there may be less risk, although there is still some risk of antibiotic exposure, even if it's a narrower regimen. Again, that's for the overwhelming majority who are found to be uninfected. And it's not clear right now whether babies who have inadequate empiric coverage have a higher risk of morbidity and lower survival. I think theoretically it makes sense that it would. If you're starting antibiotics that don't treat the infection and you're continuing those until you have your susceptibilities, one would think that maybe that baby might do worse. We haven't really found that in some of the observational studies, which we think is likely related to low sample sizes and also, again, that high baseline morbidity and mortality at that age group. If you're thinking about a broader spectrum regimen, you may cover more infections, but then you're introducing significant risks for the overwhelming majority who are uninfected, including increased risk of neck, candida infection, dysbiosis, and more. And then also, are you setting that baby up for subsequent colonization and infection with resistant organisms? So, the field is really focused on how can we identify newborns who are at risk for infection, but we really need to take it a step further and think about how can we identify newborns who are at risk for resistant infection, and how can that impact your antibiotic decisions? This is guidance, again, that's more pertinent for the US. This comes from the AAP guidance from 2018, which recommends ampicillin and gentamicin as the routine empiric regimen for both term and preterm infants here in the US. And based on the audience response, it looks like that's what most folks are doing. The guidance does briefly suggest that expanded coverage may be warranted in some scenarios, but we don't have great evidence about exactly what those scenarios are and what antibiotics to use. Based on the audience response and just what we've seen from some of our stewardship work, it looks like many centers would add a third or fourth generation cephalosporin. We used to use cefotaxime. That's essentially become unavailable here in the US. So centers are now using ceftazidime, or some centers have just stepped up to the fourth generation cephalosporin, cefepime. Is piperacillin tazobactam or Zosyn a reasonable option? And in some scenarios, is the carbapenem or vancomycin warranted? If mom has documented ESBL UTI during pregnancy, or if mom is colonized with MRSA, things like that. And I don't get into it here, but we have pretty good evidence that an empiric duration of 24 to 36 hours is reasonable if the blood cultures are appropriately obtained. And the time to positivity is not impacted by gestational age, although it is impacted by blood volume. We hear a lot about this rising concern of gentamicin-resistant E. coli. We know that about 2/3 of E. coli in the US in neonates are resistant to ampicillin. And so we get a lot of questions about why are we still using ampicillin and gentamicin if there's E. coli floating around that's resistant to both. And I think what we have to keep in mind is if you have 1,000 very preterm babies and one of them is going to have a resistant E. coli infection, resistant to AMP and GENT. But we're treating 800 to 900 of them with antibiotics. So it's not that we don't care about that one baby, but we have to think about the consequences for all of these other babies. Switching to late onset sepsis, empiric therapy, this is definitely more highly variable. We don't have national guidance specifically for this. And essentially, you want to cover the most common organisms, which I reviewed. So in many scenarios, that could be a beta-lactam antistaphylococcal like napacillin or oxacillin, plus an aminoglycoside like gentamicin or amikacin. If you're looking for expanded coverage in certain scenarios, could that be a cephalosporin? Again, Zosyn, in some circumstances, a carbapenem or vancomycin. And again, empiric duration for late onset sepsis, specifically because of cons, which can take a little bit longer to grow, we would recommend an empiric duration of 36 to 48 hours. And again, we have good evidence from my colleague, Dr. Makapade here at Penn, that the time to positivity is not impacted by gestational age. Antimicrobial resistance, this is a leading global threat to humanity. This article just came out a couple of days ago on CNN about the superbug crisis. There are estimates that by 2050, nearly 40 million people will die annually from antibiotic-resistant infections. That's more than people who die from cancer. And the risk factors for babies born less than 24 weeks include a very high risk at baseline of infection, substantial perinatal antimicrobial exposures that lead to selection pressure, prolonged hospitalization. We have limited antimicrobial options for these babies as new antibiotics get developed, which the pipeline is dismal. They usually get approved in adults and then years later in children, and usually it's a much longer time until we have any data to use those in preterm babies. And we have really scarce pharmacokinetic and pharmacodynamic data to suggest how to use these drugs, what doses should we use, and what are the side effects. In many regions across the globe, neonatal gram-negative infections that are resistant to nearly all or all available antibiotics are a daily reality. And I just shared a couple of the articles here, but in many places, this is just normal day to day, that a newborn has a gram-negative infection that's resistant to every available drug. I want to highlight E. coli as a particularly worrisome organism for babies born less than 24 weeks. E. coli is the #1 leading bacteria for global deaths associated with antibiotic resistance. And I think we don't think that a lot. We think about staph, we think about MRSA, we think about Klebsiella and Acinetobacter, but really E. coli, again, is the #1 leading bacteria for global deaths associated with antibiotic resistance. And that's concerning considering that I've shown you that it's the #1 cause of early onset sepsis for babies born less than 24 weeks, and it's the most common cause of gram-negative sepsis, late onset sepsis for babies born less than 24 weeks. Just a quick shout out to a pilot study that we've started in collaboration with some colleagues at Penn State and Seattle Children's. This is called the Siren Study, Surveillance of Invasive and Resistant E. coli in Neonates. And essentially, we are collecting E. coli isolates from participating NICUs. We're sending them to the Penn State E. coli Reference Center and sequencing them. And we're trying to get a better understanding of the genotypic and phenotypic characteristics of these strains. These are prelim data that I'm not going to get into here, but I do just want to highlight that a good portion of the isolates that we've collected, these are just the ones from Penn, are among very preterm infants, and you can see there's a handful from babies at less than 24 weeks. Many of these strains have numerous virulence and antibiotic resistant genes. And we've recruited about 20 centers, not all are shown here, in various stages of IRB and legal agreement approval. We have about 100 isolates that we're getting ready to sequence in the coming weeks. So hopefully we'll have some more information to share. And if you're interested in getting involved, please let me know. So in summary, for bacterial infections at less than 24 weeks, compared to older, very preterm infants, the incidence is different. The microbiology is different. The morbidities are different. The outcomes are different. And so the research needs are different. And so this is where the Tiny Baby Collaborative comes in. I'm greatly appreciative to Matt Rysavi and the group to help us really understand how to better take care of these babies, since we have very little data to work with right now. And then just some take-home points. For early onset sepsis, again, for babies less than 24 weeks, about 1 in 20 will have a confirmed infection. E. coli is the most common cause. And remember that 1/3 of the organisms are not GBS or E. coli. Early onset sepsis in babies less than 24 weeks is associated with lower survival, worse outcomes. And for empiric treatment, AMP and an aminoglycoside are the most appropriate routine regimen here in the US, but you should consider broader therapy for the highest risk scenarios or a high suspicion. And I don't think we have a great understanding of what that is, but things like prolonged rupture of membranes, maternal antibiotic exposure, maternal infection history. For late onset sepsis, for those who survive past 3 days, 1 in 3 will be diagnosed with a culture confirmed infection, and 1 in 2 will develop late onset sepsis or die before they had the chance. 1 in 7 will have gram-negative late onset sepsis. Gram-negatives are the most common for this group, even though for the overall very preterms, it's Cons and Staph aureus. Late onset sepsis in babies less than 24 weeks is associated with lower survival, worse outcomes, and there's no universal routine regimen. It's really not a one-size-fits-all approach. You should follow your unit's infection epidemiology and antibiogram and take it on a case-by-case scenario. And I'll just end with this. I think this is a likely scenario in the next decade or two that our care for these babies less than 22 weeks or less than 24 weeks will improve. How we use the isolates and thermoregulation, how we feed them, how we monitor them, how we ventilate them. But if they develop a multi-drug resistant gram-negative infection that you can't treat, then none of that will matter. Thank you very much to the Tiny Baby Collaborative for having me, to all my colleagues and collaborators listed here, and from Vermont Exford Network for my funding, and also to everybody on the call who listened in today. Thank you so much. I think we're going to move on and maybe take questions at the end.
Yep, that's great. Thank you. We'll go ahead and move now to Dr. Mehler's talk.
Is it fine, Noel?
Yep, looks great.
So this tiny infant, that's Sam. And he is, of course, at a high risk for fungal infections. We just learned that from Dustin. Incidence at 23 weeks and below is 4%. And the incidence is 3 times compared to 24, 25 weeks, and 8 times the incidence for 26 and 27 weeks. Predominantly, fungal infections are caused by Candida species, and rarely infections by mold, mucorales, or trichosporum. And one risk factor we talked about a lot in the last webinar is the tiny baby skin, the immaturity of the tiny baby skin. There is almost no stratum corneum. We have a poor epidermal barrier, few conified layers, no vernix containing antimicrobial substances such as lysozyme. So the skin is not an effective barrier and it is easily torn. But there are more risk factors. You have an immaturity of adaptive immune response, reduced neutrophil count and function, decreased antibody production, and there is an inadequate transfer of maternal antibodies before the 3rd trimester. You have dysbiosis due to IV antibiotics, a long duration of endovascular catheters, often more than 4 weeks, postnatal steroids, including hydrocortisone, and that's not true for everyone, but it's true for my center, a high humidity environment. And if you look at the photo I just took this morning from an incubator, you see it's looking like a greenhouse. It's all foggy and cloudy. And we've been discussing this a lot. Is high humidity necessary? How do we reduce this? And this discussion is ongoing. But there is one fungal pathogen that really thrives in this greenhouse atmosphere, and that's that. And it's causing a whitish plaque or ulceration, and we've seen an increasing number of those lesions within the last years. And if you do a swab, you will find Aspergillus fumigatus. So this infant has cutaneous aspergillosis. And on these pictures, you can see how it's spreading. It starts with a small roundish plaque anywhere on the skin. And on the middle photo, you see like it's spreading over the groin and the flank and the tummy. This infant had surgery for intestinal perforation. That's why you can see the dressings. And we just observed more and more of these infections, and we published a single center 5-year case series on this a couple of years before on non-candida fungal infections 2015 to 2020, and we found 13 infants with Aspergillus and 2 with co-infections. And what is interesting is that all infants were below 24 weeks of gestation, and most were 22 weeks. There was no antenatal fungal colonization in the moms, and most had prenatal steroids and most also postnatal steroids. And typically the lesion appears after 1 week, up to 3 weeks, and it's usually a skin lesion. It can appear almost everywhere on the skin, but it likes region where there is a skin breakdown due to dressings or heel lenses, and it can look as a whitish plaque or an ulceration, and we found it quite everywhere: hip, pelvis, groin, flank, face. And this is a very sad case because the aspergillosis developed under the dressing for a PICC line. So you can again see that blackish, whitish plaques, and it's close to the entrance of the PICC line. And what we observed a couple of days later was in the cerebral ultrasound hyperechogenic regions showing cerebral swelling and necrosis. And we think, we did a lumbar puncture then, and it grew Aspergillus, and we think that just the Aspergillus used the PICC line as a lead to go and grow via the jugular vein into the brain. And this is a picture I just took a couple of weeks before. Again, you see the whitish ulcerations and the lesions there in the region where is damaged skin due to heel lances. And this time we were lucky. This was really close to a PICC line exit again in the saphenous vein, but it didn't spread to the brain. In this picture I just took this morning, it healed quite nicely, although you see the foot there is a lack of movement in the foot, and there is some scarring that inhibited the movement for this baby now. But otherwise it heals quite nicely. And that's the good news about cutaneous aspergillosis. The case fatality rate is not high, and it's mostly limited to the skin. How do you treat it? The ESCMID guidelines recommend liposomal amphotericin B. Voriconazole would be appropriate for children and adults, but it's not approved for 2 years of age. And there is another issue with voriconazole in preterm infants I want to draw your attention to. It has a very high variability in pharmacokinetics. So it is really a challenge to achieve levels that are considered accurate. And you might need voriconazole because at one time you want to switch from liposomal amphotericin B to oral treatment. And then you're thinking about azoles. So that's just a short slide to show you how erratic and unpredictable the voriconazole concentrations are in this child. And the other problem may be an increase in liver enzymes that we observed frequently with using voriconazole. So maybe posaconazole or isavuconazole, although there is not much experience with these drugs in preterm infants, might be good alternatives. Outcome is quite good. 2 of 13 patients died and 1 survivor had severe scarring. So a quick switch to Candida. Sorry, I'm taking you for a roller coaster ride, I know, but it's only 15 minutes. Incidence of invasive Candida infections varies among hospitals. And as with all other fungal or bacterial infections, the incidence is inversely proportional to gestational age and weight. Sorry. The good news is that the incidence of neonatal candidiasis has decreased significantly within the last decade, at least in high resource settings. And the aim to getting to 0 is the goal that David Kaufman issued in 2012. And I think a lot of NICUs are on a good way. The risk factors for invasive Candida infections can be divided into non-modifiable and modifiable, or probably modifiable factors. Of course, immaturity is non-modifiable, and same is true for what I just call a bad start, low APGAR score, sepsis, or shock, long hospitalization, and as well vaginal delivery. Potentially modifiable are central venous lines, antibiotics, mechanical ventilation, systemic steroids, and parenteral nutrition, and Candida colonization. And if you have early Candida colonization in your tiny infant, it's probably from mom. It's probably due to, or a risk factor is probably vaginal birth, and it's probably Candida albicans. And if you use fluconazole prophylaxis, it will work very good for Candida albicans. If you have a late Candida colonization after 5 to 7 weeks, it's probably nosocomial transmission. It's probably non-albicans. Fluconazole will not work, but that's predominantly a problem in low resource settings. And the strains you will find are Fusii glabrata, or an emerging strain that really causes a lot of problems is Candida auris. What can you do about it? One very important thing to do is to implement strict hygiene and central line insertion and maintenance bundles. And if you have a high rate of invasive Candida infections, there have been a lot of studies. If you implement those practices, you can decrease your in central line associated bloodstream infections by 25 to 85%. And now some slides on fluconazole prophylaxis. I didn't want to talk about it too much because it would fill a whole webinar on its own, but Matt said it's the element in the room. And if this elephant seems familiar, it's Nangi from Romania. So fluconazole prophylaxis, does it work? Is it safe, and should we do it? And just a short slide to remind you that fluconazole has excellent activity for Candida albicans, no activity for Aspergillus, and no activity for Auris or Prusei, and probable maybe active for Glabrata. So does fluconazole prophylaxis work? Probably. It definitely reduces Candida colonization and invasive Candida infections, but there is no clear benefit on mortality or neurodevelopment. And this study published in 2014 by Danny Benjamin showed that the combined outcome, death and invasive Candida infection, was not different for infants, small infants under 750 grams. But there's a complexity of interpreting that results. In Benjamin's study, the rate of invasive Candida infection was definitely lower in the fluconazole administered group. It was 4% versus 11% in the placebo. And infants with invasive candidiasis, they are sick infants. They suffer from other comorbid complications of prematurity, and those are not modified by fluconazole prophylaxis. And just a calculation, if you assume a reduction in the absolute risk of invasive candidiasis of 7% in the study and a 30% case fertility rate, the difference in Candida-related mortality would be expected to be 2%. And that's the difference this study was not powered to detect. A quick word on safety. Is it safe? Probably. There are side effects. Your liver enzymes may go up, but that's not the real issue for most preterm infants. There are no effects on cholestasis, sepsis, or adverse neurodevelopment. It may increase your MIC of Candida albicans slightly, and it may be an issue for NICUs with a high prevalence of resistant strains to observe an increase of those. So should we do it? Probably, and I'd say yes for these tiny infants. The IDSA and the ECMID, they recommend fluconazole prophylaxis if you have an invasive Candida infection baseline incidence of more than 10%. And they say if the incidence of invasive candidiasis is lower, you should choose an individualized approach, considering risk factors. And personally, I think that being born under 24 weeks is a risk factor that's relevant. Dosage is 3 milligrams per kilo, administered intravenously or orally twice weekly and that's another point of discussion, 6 weeks, as long as you have a PICC line inside, as long as you're on parenteral nutrition, the recommendation don't specify. And one aspect you might to consider if you think about fluconazole prophylaxis, that in the absence of antifungal prophylaxis, up to 60% of small infants will be colonized by Candida until the 3rd week of life. And just some points on management. It's from Kilpatrick's article on neonatal candidiasis, and I think that's a really good overview. If you have an invasive candidiasis, what is really important that in neonates and preterm infants, Candida infection is not limited to the bloodstream, but it's a multi-organ involvement. So you have to obtain urine, blood, and CSF cultures to confirm your diagnosis. Whenever possible, remove central catheters and other foreign materials. And for documentation of microbiological clearance, document at least 2 negative blood cultures more than 1 day apart. That may be a challenge in tiny infants. We all know that. Document negative urine cultures and negative CSF cultures. and continue appropriate antifungal therapy for at least 2 weeks after microbiological clearance. So what is the first line recommendation? It was liposomal amphotericin B, but that has changed. At the moment, its first line recommendation is amphotericin B desoxycholate, 1 milligram per pill, because lipid formulation amphotericin B has been associated with treatment failure, especially in infants with CSF or urinary involvement, and that's most infants. They have multi-organ candidiasis. Same is true for echinocandins. They are really great options for infants and for adults, but it's not first line because they really achieve only low concentrations in the CNS and the urinary tract. If your Candida species is susceptible, step down to fluconazole, dose 12 milligrams per kilo per day. So again, sorry for that roller coaster ride, and these are my take-home points. To leave room for the discussion. For molds, immaturity, skin damage, and high humidity care are the most important risk factors. The good news is it's rarely invasive, usually limited to cutaneous infection. First-line treatment, IV liposomal amphotericin B, switch to oral voriconazole. Careful drug therapy monitoring is mandatory but complicated. Alternatives may be posaconazole or isavuconazole. You may add local bifonazole. It achieves really high and good levels in the skin. Duration of antifungal treatment is not known. We treat until the regions are completely healed. And there is good outcome, but scarring. Yeasts, risk factors, immaturity, central line, parenteral nutrition, antibiotic steroids. A lower incidence in high-resource countries due to strict hygiene and infection control measures, and fluconazole prophylaxis. First line IV amphotericin B desoxycholate, step down to fluconazole if active. And if you have an invasive infection, will see a high mortality. So thank you very much. And I'm looking forward to discuss all this fascinating infections with you. So I stop sharing.
All right, great. Thank you so much. Those were great talks, and we'll go ahead and turn over to the discussion and question and answer portion for the last about 20 minutes. And we'll wrap up around just 15 after the hour.
Great. Thank you so much, Dustin and Katrin, for your talks. I'm going to start us off with some questions that were previously submitted. I think we're having a really active discussion in the Q&A with some answers. So just to orient you, if you click on the Answered tab, you can see questions that were asked and their written responses. But to stay on the fungal theme to start us off, there were some questions asked ahead of the seminar about the agent of fungal prophylaxis, so fluconazole versus oral nystatin, and whether that choice should be, mediated by the presence of a central line or not. So I'm wondering, Katrin or other neonatologists, if you have any thoughts on that practice.
I was just, this is such a good question, Lena. A couple of things. I just wanted to just start that both talks were great too, really great. As Dustin pointed out, like when we think of the incidence in this population, the Vaughan data isn't rich with that because a lot of centers are using fluconazole prophylaxis. So we can't say it's 4%. If we look at studies that looked at all causes of invasive cancer infections, not just bloodstream, which is also a challenge with the Vaughan data, but urine, CSF, peritonitis, the incidence, and a lot of this is from the neonatal network, is closer to probably like 20%, maybe with modifiable things, 10 to 20. So really fits like the recommendations for using prophylaxis. Plus, it's not just about the incidence. I would say it's about, the mortality. And as Dustin and Katrin showed, the mortality is 50%. Canada has some nice mortality too that was even higher at 67% in these 22, 23 weekers. And the neurodevelopmental impairment, also from nice recent Canadian incidence, is like 3 times higher. So there's been a lot of nice studies, like you were saying, nystatin versus fluconazole. The challenge with this age group is, nystatin is hyperosmolar. So it's really hard to give to kids until they're on full enteral feeds. It seems its efficacy with like fluconazole starting it early, like in the first day or two, has about a 90% efficacy compared to nystatin, which is more like 66%. And also starting fluconazole later, if you're looking for a lot of risk factors, also decreases its efficacy from like 90% to 66%. And that's some of the differences from like the earlier randomized controlled trials and like Danny Benjamin's trial, which I was also part of, but we were able to start in the first 48 hours in the earlier studies, and in the less than 750 gram study, not until day 5. So I was just I know that's a lot to chew on, but like this group is really, really high risk. And like we want fluconazole to be part of the bundle to improve outcomes for these kids, in a lot of ways, survival and neurodevelopmental impairment.
Yeah, I'll say, Lena, thanks, and thanks, David. Just locally here at Duke, we're still oral nystatin, but if a kid has gotten sick and we're having to use broader spectrum antibiotics for the smallest babies, we're doing the IV fluconazole prophylaxis as well. So yeah, we're still oral nystatin, but it'd be great if there could be some sort of a pragmatic comparison trial, or at least a data collection of people choosing what they're going to choose and then tracking the outcomes by Vaughan, the Canadian network, the US Neonatal Research Network. More data is going to help us with that determination of what's better. Yeah,
there are a few small comparison studies, and like I said, fluconazole about 90% efficacious, nystatin about 66%, due to some of those reasons you brought up, the enteral route.
Piggybacking off that, I'm just going to go with one more question and then I'll hand it off to others. But one of the other things that came up in some of the questions as we're talking about, okay, if a baby is sick, do we use, and let's say has the presence of a central line, do we routinely use fluconazole or an anti-candidal agent to rule out an invasive infection? Do we use vancomycin empirically in that setting as well? Any thoughts?
If you're on
go JB, go.
I see JB.
I was trying to behave myself and let David. So I think from the antifungal standpoint, it's got to be to some degree driven by your local epidemiology and probably some recency bias. We had our first case of invasive candidiasis in a long time, a couple of months ago, and I've noticed that the rates of fluconazole treatment dosing or deoxycholate amphotericin treatment dosing has gone up because people remember. As far as the vanc goes, I feel very strongly, which is why people were snickering, that for the most we should be using oxacillin or if you have nafcillin or cloxacillin, whatever your semi-synthetic penicillin is on formulary, that should be your default. It's so effective against methicillin susceptible Staph aureus. It's effective against group B strep. For babies who truly need vanc, it would be babies who have MRSA infections. For the most part, 90+% of those are going to be colonized before they are infected. At our center, it's 96% going back 7 years. So we feel like we know who the MRSA positive babies are, and we can treat those babies empirically with vanc. Or if it's coagulase negative staph and you're sure that it's real, you can start vancomycin there. And as Dustin showed very nicely in his slides and in his response, you've got some time to figure out if it's real cons or if it's a contaminant cons, because it's not associated with mortality. It's not going to kill your baby. It's going to be inconvenient, and it might mean you have to take a line out or hold feeds, but it's not associated with mortality. So you've got time to get that one right. So I vote for nafcillin, oxacillin, whatever your available drug is. But antifungals, I defer to the smarter people on the call.
Yeah, I would agree with JB with with the antibiotic choice too, for those reasons, right? You have time for cons to grow out. But yeah, when to reach for empiric antifungals, Lena, I think if you're using prophylaxis, it's low likelihood, but if you have a kid, with complex gut disease, neck or perforation, especially if they're not on antifungal prophylaxis, or they get a third or fourth generation. Mike Cotton did great studies earlier that really showed that really wipes out all the microbia and just lets a playing field for Candida to proliferate and grow. But if you're using antifungal prophylaxis with fluconazole, you don't want to reach for treatment, empiric or definitive, because that's going to increase the risk for resistance to develop, as well as maybe you have something resistant. So you always want to reach for amphotericin or one of the echinocandins for those treatment, and save fluconazole for things like when you want to treat something just orally after you've cleared it.
Yeah, I completely agree with their both responses, and just saying out loud, not to encourage the use of these agents, but if for some reason you are using cefepime or you are using piperacillin tazobactam, those also have great anti-staphylococcal penicillin type coverage for MSSA and group B strep as well. So in those settings, unless you're specifically targeting MRSA or resistant cons you think is real, you don't need VANC for that in that scenario. Someone want to take another question?
Lena, this is more of a question than a statement, but I've seen reports of vancomycin-resistant cons. Is that something that's coming to the NICU or that we should be worried about?
We certainly see vancomycin-resistant Enterococcus, which more commonly vancomycin-resistant cons. I have not seen much of that, certainly in our practice and in Chicago. I know there are reports, but I don't know if that's an active concern for our population at this moment, although I'm interested to hear if others have crossed that thus far.
I have overheard one or two cases when talking to our colleagues, but the point is, like, whenever it's truly sepsis, the key to control the infection is take out the central line. If central line is not taken out, no matter what antibiotic we're giving, it's not going to be useful. Can I take advantage of asking another questions? Not related to fungals this time. So I've been asked many times, and I've seen some question here is, so we have a baby born at 3 a.m. is a emergency cesarean section for maternal chorioamnionitis. Baby was born at 23 weeks. Baby came out and have a septic shock, warm shock, tuck of the features, and realized the PPROM for several weeks. Mom has received multiple different types of antibiotics. The baby is very sick in front of you, requiring 2 inotropes, warm shock, apart from ampicillin and gentamicin. And the fellow called us, say, hey, should we expand the spectrum of the antibiotics to save this baby? So what will be your answer if you were the attending neo on that night? So question number 1. Number 2 is, I have heard about scenario about the 4th generation cephalosporin use. So there have been some different views from the adult side about the potential consequence of some of 4th generation cephalosporins. So how would you choose those the type of the antibiotics? So
I can jump in here. My mentor, Karen Popolo, who I know is on this call, reminds me that we're talking about empiric antibiotic decisions in the majority of cases, routine cases. There are always exceptions, and those exceptions really aren't what we should focus on. We should focus on, the 900 out of 1,000 very preterm babies that we're giving antibiotics to. So I didn't go too much into the risk factors because we don't have a lot of great data, but a prolonged rupture of membranes, particularly very prolonged, like weeks, like you said, and substantial maternal antibiotic exposure are probably 2 of the biggest risk factors for a resistant early onset infection. And so in that scenario, with a baby who's dying in front of you, absolutely give them something more than AMP and Gent. And what that should be, I don't have a great answer. I think probably a third generation cephalosporin in addition to AMP and Gent, or a fourth generation cephalosporin, maybe even a carbapenem. We know that there's very little, if any, carbapenem resistant, at least E. coli in the NICUs in the US as of data from a couple years ago. ESBL rates are low, like 5 to 10%, but they're not that much lower than Gent resistant rates. So, we have some nice data from the NRN that there is no regimen that will cover every organism and susceptibility pattern unless you prescribe 5 or more drugs. And in some scenarios, that might be the right thing to do for a baby who's in septic shock with those risk factors. But I think we have to distinguish, what we're doing for the 24-weeker or the 23-weeker who's, on dopamine and on the oscillator versus the 23-weeker who is dying and has these significant risk factors for resistant infection.
Yeah, that makes a lot of sense. Thanks very much. It's important key message is to distinguish those individual patients out of the 99.9% of the empirical usage. Thank you.
I'll just jump in, just ask a question. I would do the exact same thing, like load the baby up and make sure you cover as much antiviral as you can as well. But do we know if that's ever helped? When the kid has an NSOFA score of 1 million, me and Garg asked about NSOFA score, that they're that sick, and you're throwing the kitchen sink inclusive of 5 different antimicrobials and antivirals. Does the culture ever grow? Or on autopsy, have we found organisms that we were actually treating? Or is it the baby's immune response and that whole systemic response, not an outside culprit? Have we found that to justify what we did? It'd be, I would do the exact same thing, like load up, give the big gun antibiotics.
Yeah, I think that's unexplored territory. And, the NRN and some other work we've done has tried to determine whether babies who have inadequate or suboptimal early empiric treatment have worse outcomes. And we haven't found that, but I think it's probably because the baseline mortality for babies born at 22 and 23 weeks is so high. So can you detect that small difference? So I think it's really unmanned territory. I think we just don't know.
Quick plug, both in response to things Dustin said, which are great. One of which is talking about survival and the high mortality of these micropreemies. There's one study, and I think it was from Europe. I need to go check, and I'll put it in the chat if I can find it, that showed that coagulase negative staph late onset sepsis was actually associated with decreased mortality, all comers, because if you live long enough to get cons, you're more likely to survive, because most of these babies are dying, like Dustin said, in the first week and a half.
Maybe the Von data support that. Babies who had cons late onset sepsis had better survival than those who did not have late onset sepsis.
It's like getting a Purple Heart instead of a Congressional Medal of Honor. You must have survived. The other thing, sorry, U.S. military joke for all of our international viewers. The other thing is that shameless plug, we are our antimicrobial antibiogram is a combined one. I'm at a county hospital. We share data with the adult side, which is much bigger than us. But at my center, the rate of cephalosporin resistance for E. coli is actually higher than the Gent resistant rate. So I think we need to be conscious of, and Dr. Popolo and her team and Dustin are leaders on this in the US. We need to be conscious of gram-negative resistance, but don't think, depending on where you are, just switching to a 3rd or 4th generation cephalosporin might not be increasing your empiric coverage. So if you get appropriate volume cultures and want to start a carbapenem because you need that, that's fine. Just make sure you give yourself an off-ramp and don't get trapped on carbapenems for 10 days, 2 weeks.
There were some questions ahead of the seminar and actively in the Q&A now about whether to obtain a lumbar puncture for CSF in the setting of late onset sepsis. Being ID, I know where I love having samples and that data up front prior to antibiotics, but it's clearly, dependent on clinical stability and some of those factors. I'd love to hear from the first frontline neonatologists on that.
I'm biased too, Lena. I would also say yes. It's obviously not going to happen 100% of the time, but if you aim for 100%, you'll get we've gone from about 10% LPs for late onset back in 2017 in San Antonio up to about 70% now. And I joke with the residents, if the baby's on the oscillator and you're nervous, that's fine because the needle will match up perfectly with the baby's oscillation. These babies can be tapped more than you think they can. And I highly recommend if people are comfortable sitting them up vertically or learning how to do that, the success rate is really high and they're generally a little bit more physiologically stable than trying to curl them up on their side. So I vote yes.
So can I have a questions maybe to our colleagues? I would love to have the spinal fluid as well, but not infrequently is like we cover the antibiotics first and then do the spinal tap when the baby is crashed in front of us. So the question is like the spinal fluid is likely to have been, not to mention about trauma tap, but also frequently with some blood because of intraventricular hemorrhage. And the culture is likely to be negative for many different scenarios, or the biochemistry or the cell counts are very difficult to interpret in the presence of IVH or so. Are there any kind of like how can we kind of like resolve this issue to increase use of the CSF, the false quote unquote negative culture type of the scenario?
I know that sometimes it can be messy, to interpret protein and RBCs, especially if there's proven IVH. But I will say, I think the absence of CSF pleocytosis and knowing what normal ranges are in the first month of life can really still help in your shortening of antibiotic courses and definitively ruling out in more cases than not. Of course, there's it's all subject to interpretation, and I think we also have to remember that an infant, extremely preterm infant with bacterial meningitis will not turn around quickly, most likely, right, with the starting of antibiotics. And so I think the clinical course in combination with still interpreting CSF pleocytosis, the presence of white cells, what type of white cells there are, can still be helpful.
And I put the link in the chat, but just a reminder that about a third of babies with meningitis are going to have sterile blood cultures. So if you're systematically relying on blood, you're going to miss one baby out of 3. And for my center, it changes agent. It certainly is going to change duration. It's going to change prognosis and how we talk to families. So I would try to get it whenever you can.
Dustin, what do you make of the H flu or the Haemophilus? We had a kid recently, and it generated, at least in my head, some flashbacks. Most of y'all are pre-H flu vaccine, but maybe David remembers back in the day, H flu meningitis in kids that was just horrible. Sorry, David, but yeah, what do you make of that?
Yeah, it's not when we think about it. Haemophilus, doesn't pop up on our board exams when we think about early onset sepsis. It's, GBS, E. coli, and Listeria. But in reality, data from both the NRN and Vermont Oxford Network suggests that 8 to 10% of early onset sepsis is caused by Haemophilus. So it's definitely a significant player for early onset sepsis. I don't know a lot about Haemophilus. Maybe some of the ID folks have some more knowledge about it, but it's definitely one that slips under the radar for sure.
It is a respiratory colonizer. you know, so I think just as occasionally we'll have a strep pneumo, you know, organism or others, or a group A strep occasionally, you know, I think that we also have seen an occasional Haemophilus influenza bacteremia in these little ones. That's my interpretation of where we're seeing it from.
All right, well, I think with that, we'll go ahead and wrap up for today. So I'll just say thank you again to our speakers and moderators. This has been a great discussion, and the talks were fantastic. So thank you, and please look out for information on our next webinar. It will be held November 12th, and it's going to focus on obstetric management for tiny babies. So look out for more information on that to come soon. All right, thank you.